But here's the dietitian. So thank you for still being here. My name is Linda Gigliotti. I'm a registered dietitian nutritionist. I come to you from Southern California. Most of my work experience has been at the University of California, Irvine, in intensive medical weight management and behavioral therapy. And just a few disclosures. When I was asked to do this presentation this morning, the title was given to us, including the terms highly effective obesity medications. That raised the question in my mind, what do we mean by highly effective? Is it what we want? And certainly we have all heard about the amazing amount of weight loss that can be achieved with these newer obesity medications. But are we also taking in the comorbidities that go along? Is that part of the highly effectiveness of this or the positive outcomes as I look at it? I think more importantly, are we asking, well, what is it our patients want? What outcomes do they want? Our patients come to us usually with a sense of failure. They've often failed at other weight loss efforts because they've regained the weight back, and they don't feel good about that. So sometimes it takes an awful lot for that patient to pick up the phone or walk in the door and come to us to again try and address the weight that's bothering them. So I think from the very beginning, the support that's important to give to our patients is involving them in that discussion. Ideally before beginning the medication, but depending on when they're coming to us, at least early on, about what is it that you want out of this? Using some shared decision-making about the approaches. Talk to them about the goals. Yes, weight loss is going to be one of those things that comes out of their mouths early on. But I think to really appreciate these highly effective medications, we also have to embrace that longer-term health management. It's really important that we wrap our heads around this. The model for obesity care has changed. It's a chronic disease. I know we say that, we give the lip service to it, and we probably in here all believe that. That's partially why you're here at this conference. But has our patient embraced this? And I think, again, from early on in working with our patients, it's important to have this discussion, and I love using visuals, and often we'll scratch out the little diagram on a piece of paper when I'm meeting somebody in my office about, obesity is a chronic disease, but what does that mean to you? What's been your past experience when you're working on your weight, which is how the patient's going to say it. As I had a patient say to me one time after she lost 100 pounds and then was regaining, she said, Linda, I thought if I was able to take it off, it was like a vaccine, that would protect me from ever having to deal with it again. And yes, here I am. So I think working with this model of the narrative of obesity as a chronic disease means that, there are probably going to be some times you work on weight loss, and there's probably going to be some times that some weight comes back on, and we have to work long-term with that. I think some of my arrows are missing from the graphic there, but looking at this possibility of retreatment. So when the patient says, am I going to have to take this medication forever? That doesn't sound right. I'm like, well, I don't know if it's going to be this medication or another medication or another intervention, but we are going to be working with you on your obesity care, your health management long term. And that's where the support comes in, I think, in helping the patient work with their mindset for managing this chronic condition. So I see two counseling priorities when we're working with our patients on these GLP medications. I think the first priority is adherence to the medication, and then secondly, working on lifestyle management. So never before seen results with these medications in terms of percent of weight loss and management reduction of a number of the comorbidities that go along with it. But in order to get those results, the patient has to adhere to the medication regimen. Well, why wouldn't a patient adhere? when there are such phenomenal results that are available? Well, you know a number of the reasons. I don't need to tell you about the obstacles to access for the medication, limited supplies, not being able to fill or refill a prescription. You're very aware of the cost concerns with the medication. It's been reported that 47% of patients who want to use the medication decide not to because of the cost. Insurance coverage or not coverage and stopping, all of those are certainly barriers to adherence to the medication. But let's kind of assume for a minute that our patient wants to take the medication, has access to the medication, has coverage or can afford the medication, and they're now going to take the medication. What are some of the concerns that we have, and where could we offer support in terms of adherence to the medication? Well, first has to do with the actual administration of the medication. How many of our patients have administered a medication subcutaneously before? Not most of them have not. And while I realize that the single-dose syringes make it relatively easy, they still have to know exactly how to do it, where to inject, etc. And now some of the medications are available in vials. Does the patient know how to draw up the medication into a syringe, the correct measurement of it, and administer it correctly subcutaneously? Who's assessing that? Who's teaching the patient? Who's assessing? You know that many of the medications are now being prescribed in primary care offices, perhaps even some virtual with very limited human contact. Who's going to be assessing the administration technique? That's really important to get the results that we want. So that kind of support, whether it be from a diabetes educator or a registered dietitian nutritionist practicing at the top of their scope, is able to teach, assess, and evaluate along the way. And not just the first time, but including that in our monitoring and ongoing assessment of the patient as well. This is important to get the results that we want. I think the other part of the assessment that we sometimes don't pay as much attention to is the dose that the person is getting. You know that the protocol is to start with the lowest effective dose and then to advance it per the protocol for the medication. But we need to be working with that patient to assess along the way their tolerance of it, and is it needed to increase to the next dose, or should we be slowing down the progression or even back off a little bit? The optimal dose for the patient is not always the highest therapeutic dose. That's part of the ongoing assessment and the support that we can give to the patient to make sure that they get the best benefit for themselves from the medication. The other part having to do with adherence, and I think this probably will hit home a bit more with most in the room, is that medications do have side effects. And those side effects can lead to discontinuing the medication. The side effects were reported in 10 to 30% of those taking the meds in the trials, and with 5 to 10% of people actually stopping the medication during some of the clinical trials, stopping due to the side effects. But what about in the real world when the patient is not on a clinical trial and they're not perhaps receiving the direction or the support? A study of patients with type 2 diabetes who were prescribed the GLP-1 medication, 50% discontinued treatment within the first year, likely due to gastrointestinal side effects. So those side effects can affect the patient's adherence, also can affect the nutrition and fluid intake, and the patient's mental well-being. So how are we going to support the patient through that? Yes, we can advise them that those side effects are transient. So here are some tips for hanging in there through the first few days. And yes, those side effects may return when you go up to that next dose, but you know it's not going to be forever, and here are some strategies for managing. I think it's also important that the patient's very comfortable with communicating with us about the side effects, they may not be as willing to communicate with the provider who's prescribing the medication because the patient wants to lose weight. That's still, right? I'm seeing Dr. Fitch nod there. I want to lose the weight, and I'll just tough it out staying on the medication. Well, we don't have to suffer that way. We can help them. So we, whether it's the dietitian, the diabetes educator, may be the one who needs to communicate to the provider, hey, your patient's having these side effects, can you help? Maybe the dose needs to be lowered. That's all part of that overall management. So there are, I think, very practical tips for managing these gastrointestinal side effects. Most of the side effects are gastrointestinal side effects. Dietitians in the room, the GI tract, the gut, isn't that our organ? Don't we work with that a lot, with these side effects, with so many different disease conditions with our patients? So there's a number of just very practical strategies for working with these. Not everybody is going to experience, not everybody is going to need an in-depth referral. But I think if we can modify in the moment when the patient's experiencing the side effects, they're much more likely to stay on the medication. I think this is the reason that we really work with our patients, start low with that dose, go slow, and tell us about it. Probably one of the biggest strategies for managing the side effects is to eat smaller portions of food than usual. Now, they may be doing that anyway because they have a decreased appetite, but to eat regularly, spread it out through the day. Eat slowly, pay attention to your body, and recognize signs of fullness, which may be a new behavior. Limiting high-fat foods or spicy foods. And as Dr. Bays has so clearly indicated this morning, staying hydrated really helps with managing the nausea there. Constipation happens. Well, high fiber is really one of the best strategies. So what did Dr. Fitch tell you? Vegetables, fruits, whole grains, so forth. Again, staying hydrated. I think we can all really, really emphasize how important that is. Physical activity, just anything to stimulate the GI tract can help as well. And sometimes we need to use fiber supplements or stool softeners if the constipation is severe. Diarrhea sometimes happens, so avoiding sugar, alcohols, and many of the artificially sweetened items, perhaps modifying beverages, whether it's alcohol, caffeine, carbonated beverages, and fiber. And here we are again, staying hydrated. So working with the patient, just slowing down, eating smaller portions. Most of these side effects are transient, and they're manageable. So just talking, sometimes just the support of listening to what the patient is experiencing, they don't have to be doing this on their own. So now we have the patient with access to the medication, they're tolerating the medication, they're doing great with weight loss. We know that lifestyle counseling has been kind of the foundation of all interventions for obesity, and traditionally has been included. It was certainly part of the trials for these medications, but some people are asking out there, with the spectacular results of weight loss that are being achieved, is there still a role for behavioral or lifestyle counseling with use of these medications? So let me emphasize, a prescription for an obesity medication is not quality medical obesity care. If only the weight's addressed and the other comorbidities are not addressed, then I think the use of these medications is stigmatized and is contributing to weight bias. Please don't refer to these medications as weight loss drugs. Please don't let your patients refer to them as weight loss drugs. They're obesity management medications, and I'm going back to that model of obesity as a chronic disease. We have comorbidities associated, and we need to practice the lifestyle behaviors for that long-term health management. I think that's some of the best support and advice we can give to our patients with really working to manage this chronic condition long-term. But the lifestyle message has to be redefined. Our patients are dieting veterans. They think they know what to do, but what to do has now changed. And I think us as registered dietitians, as health professionals, need to accept that message too, that how to do this is really changing. We are shifting from inducing weight loss through caloric restriction to facilitating adoption of food, dietary, and activity patterns that promote optimal changes in body composition and long-term health. So again, the lifestyle focus within the context of these obesity medications needs to refocus and move away from a diet or reducing calories, but rather looking at enhancing the weight loss, enhancing body composition, as we've heard, and look at that lifestyle management, long-term management with comorbidities as well. So I think there's really a greater need for this lifestyle counseling going along with these obesity medications because of that longer-term focus on health management. We know that lifestyle interventions provided by registered dietitians and other health professionals make a difference. A systematic review of 62 RCTs revealed that participants who received counseling with a dietitian, in this case, had decreased body mass index, decreased waist circumference, decreased systolic blood pressure, improved quality of life mentally, and better percentage of weight loss. Other studies have shown that counseling provided by registered dietitians has been shown to improve outcomes in dyslipidemia, prediabetes, hypertension, and oh, by the way, aren't they many of the comorbidities we're working with obesity management there. So what does this support for their nutritional intake look like? And I think I'm going to be repeating some of what you've heard, especially from Dr. Fitch, but also Dr. Bay, but to drive the point home. These patients on the medications have a decreased appetite. There tends to be less interest in food, lack of a desire to food. So it's really important that what the patient is consuming is nutrient dense, has the nutrients in it. So using smaller portions to help manage that decreased appetite, eating slowly, stopping at the signs of fullness. I find that using a hunger fullness scale can be a valuable tool to help that patient in paying attention, maybe for the first time, some mindfulness about what's going on in their body. There's often the need for structure. The patient may come to you without a history of eating on a regular basis. So talking about meal timing. Patients say they sometimes forget to eat. Oh, I'm not hungry. I forgot to eat. Okay, maybe it's as simple as setting the timer there, an alarm on your phone as a reminder. But also make it a little easier for them. And you heard this from Dr. Fitch, prepared foods, whether it's ready to serve, a meal delivery service, perhaps, maybe it's meal replacements, but certainly easy. This isn't the time to give the patient a long grocery list and send them to the store if they're not used to preparing foods. Start with that structure. Identify where the patient is in terms of stages of change. I love your example of carrots. Hey, if that's what the patient is willing to eat, we're going to start with carrots. Adapt versus radical changes, micro changes, so that the patient's very comfortable with that, and then build from that. And then when we look at the macronutrients, you have heard from all of us how important protein is. That gets the major emphasis to minimize the loss of lean body mass. When we're working with the patient, I think one of the tools that we as dietitians need to keep in mind is the nutrition-focused physical exam. Looking and assessing for perhaps too much muscle loss. So what's a healthy food plan? We want that patient, we say nutrient dense, a healthy food plan. We want to get in all of those macro and micronutrients. And it is the opportunity to practice new behaviors. But what does that healthy food plan look like? So I put this up to say, well, there's really a lot of debate about what a healthy food plan is. On the left side of the screen there, you see the blue column, and we're looking at a variety of eating patterns, I'll call them, and then really, when we look at the literature, any number of benefits have been found with most any of those food plans. So my point is, I don't think we need to get hung up on a particular food pattern for our patients, but rather to work with them looking at food categories. So I like this graph, or chart rather, that down the left side, you see various food categories: dairy, fruit, vegetables, beans, animal protein, fats, oils, nuts, seeds, and so forth. And then across the top, you see the various eating patterns that I just showed you on the previous slide. And what you see with all those check marks on there is that most eating patterns include most every food group. And to emphasize the protein here, we can get protein from any number of these food patterns. So I think what's really important, and the takeaway message here, is that we want to emphasize the foods that are nutrient dense: vegetables, fruits, leafy greens, berries, whole grains, nuts, legumes, and so forth. Get the protein there, whether it is from beans, peas, lentils, animal meats, fish, eggs, dairy, etc. But work with our patient in terms of what are their food preferences, what are their cultural preferences, their ethnic preferences, what's available, what can they afford. And then work with them to include this variety of foods, minimizing the highly processed foods that are certainly not as nutrient dense. There isn't room for them in their food plan at this time, at least maybe half the donut for sure. It's not a forbidden food, but we need to have all the other things as well. So I absolutely agree, no forbidden foods, but maximizing the nutrient-dense foods. One of the things that's really unique with these medications is that we hear from many of our patients about the dampening of food noise, that relentless and distressing desire to eat, even to the point of weight gain. Whether it's mismanaged signals between in the brain and the body, I don't know. We can delve into that another time, but I think the important point to keep in mind is that this actually creates a window of opportunity for us, that if the patient is not feeling that drive to eat, they are much more open to healthy eating behaviors during this time because they're experiencing fewer cravings and less temptations. So it's a kind of a golden opportunity to work with a patient on their food choices. Now, I've talked mainly about the food plan, and that's certainly important for getting in the nutrients for healthy body composition and overall health. But we have to remember that the medications work on the eat less side of the equation. They do not work on the move more side of the equation. So part of our support for these patients is to support them for that moving more, for physical activity. We all know all of the health benefits associated with physical activity, and they go well beyond the benefits with weight. Really have very little to do with weight loss, more important with weight management, but also very important for management of the comorbidities. I think our job in working with patients with all these medications is to really support them in moving more, and patients need a reason for doing things. So I think here's where we can tune into your muscles. Patients want to be losing the excess adipose tissue and to emphasize the role of physical activity in protecting muscle mass along with their protein intake. So that is important to use the muscles while they're losing weight. There's great discussions going on about the role of aerobic exercise as well as resistance training, but to move more. And we're going to use very similar strategies as we did with food. Think of starting slow, adapting micro changes there. Can you walk out your door 5 minutes and turn around and come back? Have trouble with weight bearing? Let's do some chair dancing. Let's look at things that are very practical and build from that. This is, I think, a good place for fitness trackers, just to track moving. No magic numbers, just move more. Mental health is important. Dr. Fitch alluded to this. There are changes in body image, and I find that very often when patients have significant weight change, particularly when it's rapid weight change, they're not prepared for those changes in body image and how the rest of the world reacts to them. It's a time to discuss unrealistic expectations with patients. Just because they've lost a significant amount of weight doesn't mean their job situation, their family situation is going to change for the positive. There may be more attention on them, and I've worked with a number of patients who are just very uncomfortable with themselves with that significant weight loss to the point that they've sabotaged the weight loss and regained to their old self because at least there was a comfort level. Working with them and discussing this along the way is certainly a very important part of the support there. So we know the medications aren't a magic bullet. We're accepting it as a chronic disease and focusing on that comprehensive care. Treating the whole person is the best support that we can give the patient. Treating the condition, not the symptoms. And I think as we work on some of the case studies now, take a look at this, we'll be looking at that comprehensive approach to obesity management. Thank you.